Can everyone hear me? I think this is good, right? I'm Nick Desai. I'm the CEO of a company called Heal. We do house calls. Has anyone in here used a Heal house call by any chance? No? Okay, we do house calls. We're an app-based solution that lets you hit a button much like requesting an Uber, except within 2 hours, a board-certified licensed medical doctor will show up to your door, 8 a.m. to 8 p.m., 7 days a week. I spoke here last year, and at that point we had seen just under 1,000 patients. We were excited to say 1,000 patients at the time, and we had not, we were still only a cash pay service. It was $99. You paid cash for the doctor to come to your house, which was a pretty good rate, but still we were a cash pay service. This year, a year later, we are now in network with all of the PPO insurance plans in California, Anthem, Blue Cross, Cigna, Aetna, United Healthcare, and Blue Shield of California. So your Heal house call costs no more than going to a doctor's office, the same $30 copay or whatever your copay is to go to a doctor's office. You can get a doctor to come to your house. And we accept Medicare, and we have now seen well over 10,000 patients. That's the growth story part of the story. Raised another $36.5 million in investment capital since I last spoke here. And we now see about 2,500 patients a month. So that's the growth story. So why is that interesting? Why do we do house calls? What's really behind it? What is it that we think we can achieve with this that's really interesting in the context of healthcare? Obviously, we want to build a profitable business. But the house call's appealing. Does anyone here actually like going to a doctor's office? Okay, no one likes going to the doctor's office, right? ER, urgent care, doctor's offices, anything. There's nothing better than a doctor coming to your house when you're sick or your family members are sick. And for a lot of people, over 4 million people over the age of 65 that have been identified, and it's probably 3 times that many, are not able to get to a doctor's office, and of the people under 65, over 25 million have been identified as unable to get to a doctor's office in a timely manner because of economic reasons, transportation, vision, ambulatory, altered mental status, all of the different factors that involve that. This business doesn't work, and this is what we'll spend some time talking about, unless we reinvent the business process of medicine. Because the first question anyone who knows anything about medicine is going to ask, but, well, Nick, in a doctor's office, a doctor sees 40 patients a day, and there's no way they can see 40 patients a day on the road, so how do you make money, right? So we have to reinvent the business process of medicine to be able to make money, because our investors are actually interested in us making money. And being a network is critical, right? You cannot be... If you want to be an expensive urgent care replacement that comes to your house, sort of concierge on wheels, concierge on demand for 100, 200, 300, 400 bucks, you can do that, and we could do that, and we would be used once or twice a year by families with kids when the kids get hurt on Saturdays and Sundays. If you want to be your family, if we want to be your family doctor, which is what we want to do, we want to be your family doctor in your family room, right? For you, your kids, your parents, everyone in between, then we have to accept insurance. That's critical, right? And the question then is, why do insurance companies want to work with Heal? Why do doctors want to work with Heal, for that matter? So we have to demonstrate cost savings, right? If you're a PPO insurance company, if you're a large self-insured corporation, if you're Medicare, if you're an ACO, everyone's interested in saving costs, except the patient. The patient is interested in saving money, but more importantly, the patient's interested in better health outcomes. And when better health outcomes are the thing that can lead to cost savings, you have a truly win-win situation. Doctors feel better about practicing medicine when they can deliver results that make patients happier and healthier. Insurance companies love that. The people who pay for healthcare, insurance companies, Medicare, large corporations, and patients, of course, who doesn't want to be healthier, right? Who wants to actually be sick? So we have to be able to demonstrate cost savings, and we actually are, and we'll get into some of that data. So who is a team changing healthcare? Our chief medical officer is Dr. Renee Dua. She's triple board certified. She was chief of medicine at 2 hospitals. And she's also my wife. And we started this company together. And then there's me, that's that guy. I've lost a little bit of weight since then, I think. We have a pretty impressive board of advisors. This is 4 out of 12 that I decided to feature. 2 PhDs and 2 MDs who are helping us develop better clinical care, better approaches to medicine. One of them is a professor right here at Stanford, Dr. Krishna Shenoy, a good friend of mine who does work in neural prosthetics. And we have, at this point, across the state of California, we have 70 doctors working with us. One of the interesting things about Heal, which we'll get into, is that our doctors are with us full time. These are employees or full-time contractors, but they are not, they're not getting paid on a per-patient basis. There's absolutely no financial incentive to rush through the patient, right? And that has a lot of advantages, right? Now, in this room, I'm not going to spend a lot of time talking to you about why it's a broken system and how broken healthcare is. I think you all know that. You probably wouldn't be here. I don't think this conference would exist if everything was hunky-dory, right? But some of the stats that blow my mind are that of the 3.8 billion prescriptions written every year and filled every year in America, over 50% of them are never actually taken. They're filled, they're paid for, and they're sitting in people's houses or down their toilets for that matter, right? Which has its own set of problems. This one just came out. Dr. Aaron Yao just published this in conjunction with Medicare and JAMA. I think you could see it in this month's JAMA. 65% of people living in skilled nursing facilities and assisted living facilities would rather be dead than get the quality of care they get right now, okay? There's nothing that says care is insufficient when you'd rather actually be dead, right? And to provide care that's considered adequate by the Center for Disease Control, primary care doctors would have to work 21.7 hours a day, 365 days a year, right? Some of them are working pretty close to that already, but this asymptotically approaches insanity, right? And that's where doctor dissatisfaction, by the way, comes from. And we also have a very transactional approach to healthcare. What all of this leads to, right? I was having this conversation with the data scientist we're recruiting, and we talked about, well, you know, what about having specialists? Because right now we have primary care doctors, family medicine, internal medicine, and pediatrics. He said, well, what about specialists? And Renee was there, and she said, look, you know what's interesting about specialists is a lot of what pressure is on the primary care doctor who has to get through and chart 40, 45, 50 patients a day is, okay, you have a GI problem, let me get you to the GI doctor. You have back pain, let me get you to the orthopedic surgeon. You have this, let me move you out. It's about production line, it's about inventory. That problem is exacerbated and worse in an ER urgent care where they're trying to either move you up or move you out, right? Get you into a bed or get you into the hospital, right? Oops, now I have dropped my microphone. Overcome with enthusiasm. And it leads to people who are either, and both ends of the spectrum are wrong, right? We live in a country that simultaneously has up to a third of the population chronically underdiagnosed, right? Whether you call them HCC patients, whatever you call them, they don't care. They're just sitting there with many, many comorbidities. And on the other hand, you have about a third of the population that's way over-medicated. And what we're learning now is that what we know now is that each additional medication has a chance of complicating the effect of the first medication and making you worse off than not taking the medication at all, right? So there's a lack of continuity, integration, care. Yet at the same time, we know more than ever that it's only if we can truly combine longitudinal health history, family health history, genotype, phenotype, environmental factors, right? All of these things into a person's diagnosis and treatment plan that we can truly adequately treat them in the best, most effective, most cost-effective possible way, right? I always take this example. I'm a 46-year-old guy, and over the last 3 months, because of back pain, I've lost 36 pounds and am getting fit because I wanted to get rid of chronic back pain, and it actually works, by the way. But if two 46-year-old guys came into the doctor's office and both had high cholesterol and both worked a lot like I do and both had 2 little kids and one of them had lost 36 pounds in the last few months, and if you open their fridge it was full of kale and bok choy basically, which is what I eat all the time, and the other one had a fridge full of cheeseburgers and hot dogs and frozen pizzas and was 36 pounds heavier, you might put one on Lipitor and you might put the other one not on Lipitor. Right? The other classic example, because I have little kids, is you go to the doctor's office because you think your 3-year-old has asthma. It turns out he's allergic to the neighbor's cat who comes over and plays with him sometimes. The environmental factors that we can see by going into a patient's house enable us to practice a better quality of care combined with genotype, phenotype, and all this information, right? So how do we attack these issues? We reinvented the back office of medicine to cut out the operating cost 65%. We've already done this. We are actually gross margin profitable in our busiest, largest market, which is Los Angeles, California. That means we are generating more revenue per day than it costs to pay the doctors per day, right? The doctors and medical assistants who go to people's houses, right? And when I say medical assistants, that's accompanying a doctor, not in place of a doctor. You always get a doctor with Heal, right? We did this by using available and novel software that we developed. We worked with an EMR provider, Dr. Chrono, that has open APIs, a company called Eligible APIs that's developed 270, 271 exchanges with the insurance company's back ends. So for all the way from when you request a visit, using the Heal app or website, to the point where we pre-authorize your insurance, to the point where we send the doctor comes, the chart is taken, the note is written, the bill is sent, the money is collected, the revenue is reconciled, the doctor is paid, your prescription is filled, you're notified that your prescription is filled. 100% paperless, humanless, errorless operation. The average primary care practice in America has 18 to 25% of its bills go unpaid. We have, out of 8,000 claims we've sent to insurance, 2 have gone unpaid. Right? And I'm still chasing those 2. I'm going to get them. This is how we have fixed medicine. We reduce ER overuse by 62%. There's a large tech employer here in the Bay Area, very, very large, very prominent, but I can't say, but one of the ones you would have heard of. If I were to say name a tech employer in the Bay Area, it would be one of the 5 names you'd say, that is on track to save $2.9 million this year just in reduced ER costs by making Heal available to their worried well employees on evenings and weekends for their kids, right? Which is to say nothing of the fact that if you're a highly paid engineer at one of these tech companies and you spend a half a day to take your kid to the doctor, that costs money, right? And if you can instead book a visit at 6 o'clock in the evening when you normally get home, that costs you, that's not, the lost productivity isn't there. How do we do increased compliance in medication? I'll bet you at this conference there's 10 different startups presenting ways to track medication compliance. You know what the best way is? To have the doctor say, let me see your pill bottles, because they're in your house anyways, right? And say, okay, well, you're not taking this one, so I'm going to stop writing this one. Or this one and this alcohol you're drinking are not going to work well together, right? Or these kinds of things we are able to gather and store. In fact, we have built out in the EMR, and we are storing with patient permission for the first time things about the environment, things about notes about medication compliance that we're observing. We're asking people to see their fridges, what's in their refrigerators, what's in their liquor cabinets. Is there mildew in the bathroom? Is there smoking in the house? How many people live in the house? What's their health history? All of the integrated care based on exposure to the home environment. Coupled, and this is, by the way, you know, there's a revolution. I don't know how many companies here are presenting different technology-based solutions, right? From wearables to trackables to swallowables to Band-Aids that track serum creatinine and all of these different, these parameters, right? Who's ever going to get the 80-year-old person living in an assisted living facility who actually needs to have their creatinine tracked to actually wear one of these Band-Aids? The only way it happens was when you solve the last mile problem, which is a doctor who comes there, sits with that person on family day when that person's son or daughter is there, or wife or whoever, loved one, and explains the importance of this Band-Aid, puts it on the patient, and then uses that data to proactively alert the patient or the family when we need to come in and see them again. And when then we can actually send the doctor to see them again. So closing that loop between data, technology, environment is only done by the last mile, which is the doctor at home. And what we want to do now, why did we raise all this money? Hey, we're gross margin profitable, and hey, we've already reinvented the business of medicine. That's kind of cool, but because we want to reinvent care delivery. We want to reinvent what care actually means. From high-touch house calls, which is what we do now, right? That's an expensive proposition. There's only so many doctors, and there's only so many hours in the day that we can do this. So we're extending into disease management, senior care, integrated care, and health data management, right? Every time we see a patient, we ask them to get their health records and do the work of manually getting health records, no small feat, by the way. But getting into care delivery and provider expansion, more complex cases, post-surgical discharge. We've just won our first contract with a major hospital group to see post-discharge patients that have congestive heart failure. Very high risk of readmittance. We all know the problems and costs associated with readmittance. We're now taking on those patients and build case management protocols, right? Specialists, nurses in physical therapy, when appropriate and when the doctor feels it's appropriate and okay to send that person, right? When I was told 3 years ago, when my back pain started, get physical therapy, I took the Meteorol dose pack, right? But I didn't do the physical therapy. When the pain came back and my wife is like, look, they're going to cut you open if you don't do physical therapy. That's when I went to physical therapy. But what if the physical therapist could have come to my house, right? And then remote diagnostics and genotype-based care and algorithm. The whole goal is to take the explosion of data, right? So a very simple example, you start a new medication for whatever, and you wear a Fitbit, and you've given us access to that through Apple Health Kit, and we start noticing that your number of steps goes down from about 7,000 steps a day average to about 2,000 steps a day. Maybe that medication's making you sluggish. Maybe it's making you tired. Maybe it's making you eat more. Maybe it's making you eat less. Maybe it's exacerbating some other problem, right? These are the kinds of things that we're going to start looking at and start doing, and that's why we're hiring data scientists and cybersecurity PhDs along with excellent doctors to deliver that frontline care. 10,000 patients, have used Heal for all these kinds of things. 40% of patients make us their primary care doctor. Heal is the primary care doctor for about 4,000 households at this point throughout California. 73% of patients pay with insurance, and we've grown by 820% over the last 12 months. These are just some of the reasons people use Heal. And as we get into Medicare, we just started accepting Medicare, you will see more chronic disease management, more palliative care, more care for homebound patients, more of those kinds of things. This is an important case study. This is just a program we've won. Blue Shield is the largest in-state Blues plan in the country. They have 4 million insured lives in California. They did put an RFP for a company to be a residentialist. This is a word we hear in healthcare now, the residentialist concept. And they were thinking about this for homebound patients and for patients in palliative care and HCC and patients who can't make it to the doctor's office. And we ended up winning the contract, not just for those patients, but for the first time ever, a large insurance company in America will make house calls available as a primary care option to all of their insured patients throughout the entire state. And that company is us, and the partner is Blue Shield, and this is what they had to say about us, right? And part of what we did to win this contract, it's very interesting, is 3 things that I will leave you with, and then I will close. The first is, obviously, we showed them the technology platform. Right? And part of that was price transparency for the consumer. Have you ever gone to the doctor's office, paid your copay, thought you were doing whatever? If any of you have kids, I'm sure this has happened. And then you get a bill a few weeks later? And like, wait, you were in your deductible period, you weren't in this, you were not, copay, out of pocket, self-pay, whatever it is, that wasn't covered, right? We guarantee you will never, ever get a bill from us. Because we pre-authorize the nature of the visit with the insurance company. We know how much we're going to get paid. We charge you what we need to charge you up front from $0 to $99, your copay, the full cash rate, somewhere in between. You'll never ever get a bill from us, right? The second thing we did was we showed them that doctors are happy with Heal. Why are doctors happy with Heal? Because they get to see 15 patients a day instead of 40, and they get to make the same amount of money. We go to doctors at Sutter, Dignity, Kaiser, Stanford Health. We've taken some doctors from you. Cedars, UCLA, UC Irvine, all of the Regal, and we say, hey, how much are you making? I'm a family practice doctor. I make 180 grand a year. How many patients do you see a day? Well, I work 45 hours a week. I see 40 patients a day. Okay, how much of your time is spent in unpaid charting and meetings? Well, about 20 hours a week. Okay, well, we're going to pay you the exact same amount of money except there's no unpaid time. Because you're going to be driven around by a medical assistant. You're going to have a tablet-based EMR, and you're going to chart between visits, right? So we are winning and hiring some of the best doctors in the state and in the country to serve Heal because they want to practice medicine. 50% of doctors say they're burned out or very frustrated with their careers. 9 out of 10 would say they would not send their children to medicine. And doctors estimate that 40 to 70% of their time is spent doing paperwork. This is all publicly available data. Paperwork and bureaucracy, we get rid of all that. We get rid of it and let them focus on why you went into, nobody goes into family medicine or pediatrics anymore to become a billionaire. It's not gonna happen, right? Li Kai-shing notwithstanding, it's not gonna happen. It's gonna happen, what people go into medicine for is the love of making people feel better and medicine. So we showed them that. And the last thing we showed them was the future, right? How we are reinventing care delivery, how we can take care of a broader range of patients with price transparency, with happy doctors, and close the loop between the discharge, so the person who goes to the urgent care, then they end up in the hospital, then the discharge, and then the primary care, then the therapy. We can close the loop between all those data points by being in the person's house. So that's it. Thank you. I will open up to questions. These are some quotes. People seem to like us. And that's it. Thank you. Question in the back. So that's a great question. We are open 12 hours a day from 8 a.m. to 8 p.m. The doctors who work a 12-hour shift, and the beauty of HEAL is that doctors often like working 12 hours in a day, but less days in a month, right? And they get to do that with HEAL. But they don't have to work the full. If an average doctor who's in LA, which is a high traffic market, and there's a lot of traffic, will spend approximately 5 hours a day in the car and 7 hours a day with patients. So we allow doctors our full-time doctors get to decide, and their salaries are obviously related to this, between working 3 to 5 12-hour days per week. We don't let them work more than 5, and we don't hire them if they want to work less than 3, right? But most of them work about 4 12-hour days per week, and they take 3 days off. But they bundle it in some very interesting ways. There are doctors who will work, so if you take 4 days a week times 4.5 weeks a month, you get 18 days. And there are doctors who will work basically 18 out of 19 days and then go take a 12-day vacation somewhere, right? Or not 10-day vacation somewhere. And there are doctors who's like, no, I just want to work every Monday, Tuesday, Friday, and Saturday, right? And that's what they get to do, right? We have a lot of husband-wife couples who are doctors, and one works 3, one works 4, and they get to be home with the kids too, right? So there's a lot of interesting advantages when you extend the hours of a typical medical practice, which is about 34 hours a week that they actually see patients, to 40 hours a week maybe, to 84 hours a week. Well, we're only 16 months old in terms of date since launch. So this is from the last MedX to now, which I thought would be an interesting data point. Yes, that's a great question. How did we convince the insurance companies? And now that we actually have all of them, I'll tell you the honest answer. A few years, we have large corporations who are self-insured who promote HEAL as a primary care and urgent care and preventative care options to their employees, right? One such company is a small tech company here you may have heard of called Google. I cold emailed them. This is last April. Said, hey, you should offer HEAL to your employees. You may as well. You offer everything else. Right? 2 weeks later, I heard back. And they said, are you in network with Blue Cross? Because even though we're self-insured, our TPA is Blue Cross, Anthem Blue Cross. So I said, no, but we will be. And I said, could you do me a favor? Could you email Anthem Blue Cross of California and say you want HEAL in network? Well, guess what happened? They did. And then Anthem contacted us, and 2 weeks later we had contracts from Anthem, and then I emailed an email to all the other insurance companies saying, hey, Anthem's going to work with us, do you want to? And by January of this year, we were insured with all the insurance companies in the state. That's how we did it. Yeah, so the answer to the first question is, no, we have staff to help them with that, right? That's one of the beauties of HEAL. And the answer to the second question is, no, we're not going to white label. HEAL is the brand. Right? And because we do things that no other medical care, not only do we come to your house, right? One of our investors has this phrase, which isn't politically correct, but it's easy to be the tallest midget in the room in healthcare, right? Healthcare sucks. It's easy to be a little bit better, right? We don't want to be a little bit better. We want to be so great that you think nothing but HEAL is good enough, right? And the way we do that is the training we give doctors, not clinical training, they're already excellent clinicians. What if there's a pet in the house? Wearing the HEAL coat, the badge, how to say hello, different cultural customs, how to follow up, our phone support that's available in 3 languages, right? Like all of the different things where you get a copy of your medical records emailed to you 24 hours after your visit, 100% of the time, right? All the things that we do are within the context of the HEAL brand, and we're not interested in being a technology licensing platform. So the challenges that doctors face are increasingly and asymptotically approaching minimal, right? We're integrated with software that checks that address and makes sure there's no child, that the doctors aren't at risk going there. They're accompanied by a medical assistant. Early on, there was a lot of logistics issues, to be fair, right? The MA wouldn't have packed the ophthalmoscope or in the kit, and then the doctor doesn't have it, or the rapid urine strips are, the doctor says, okay, I'm going to give you a strip, and then there isn't one. We've figured out how to remedy some of those problems. We also have a very good keyword-based system in the symptoms field to detect when we feel like we should call a patient and say, look, you need to go to the ER, or we're not able to do this for you. For example, we don't do medical marijuana. We don't prescribe anything that requires a triplicate, right? We're not a rich people's Vicodin refill service, right? And then we all know how big an issue that is right now in the country. So we've gotten pretty good at those kinds of things, right? So I would say the doctors we are facing some pains of growth, but the doctors are relatively shielded from that. Well, that's exactly what we're going to start doing with a major group down in LA. You would know the name, I can't say it publicly yet. But for post-discharge, post-ICU, post just regular discharge patients, but that are very, have real illness that they need to be monitored closely. So our doctors would monitor them. The case manager, there would be a case manager that would be kept in the loop, and there would be the discharge doctor, the intensivist, the hospitalist, whoever it is, kept very closely in the loop about what's happening and what is the right appropriate care. One of the key aspects of that I didn't get to, right, is that we are not, as a country, doing a great job of classifying if someone belongs in palliative care, homebound care, assisted living, skilled nursing, senior care, the actual hospital, or none of the above. Right? We're not doing that as a great job because those decisions are often not being made by doctors, right? The entire business of assisted living is kind of a shady business that's done with, in a lot of ways that are really, frankly, a little bit unethical in my view. But the fundamental thing that's missing is a doctor who can evaluate and know the patient, know their history, talk to the intensivist and say, okay, what's going on here? And put them in the appropriate kind of care environment where the patient is willing to go into that care environment, understanding there's a doctor who can come there, right? In addition to going to people's houses, we go to assisted living and SNF facilities all the time, right, for our Medicare patients. Yeah, closing the loop between system and facility-based care and outpatient care is a critical part of what we want to be a part of the solution of, right? Which is, how does that loop close, right? If you're Kaiser and you're discharging patients at the rate of 100 a day, right, how do you know what's happening to those people? 1,000 a day, probably. How do you know what's happening to those people, right? And how do we know when it's the right time to send someone back, right? There's a loop that has to be closed there. And the openness of data in healthcare, I don't mean violating HIPAA, I mean the technological limitations that are preventing us from adequately sharing data are part of the problem, but the systemic approach to, I want to own the patient in my building is also part of the problem, right? Whereas the patient should be in charge of their healthcare and we should all be enabling and helping them, that's part of the details we have to combat. I think we need to move on to the next one. I'm at DJ NoFunk on Twitter and Nick at getheal.com on email, and thank you everyone.